So after we have discussed failing blebs, I invite Professor Dr. Andrew Braganza. So he is the professor of ophthalmology at CMC Vellore. In fact, except myself, all the other speakers are former Vellorians. So Dr. Andrew.
No, Andrew.
So Dr. Andrew will talk to us about hypotony, which is one of the most common complications in TRAB. So he will give us the complete lowdown on hypotony.
Okay, good afternoon, everybody, and I hope that the lunch is not having too much of a somnolent effect. So the lowdown on hypotony, what do we define it as? Generally, one says pressure less than 8 millimeters, maybe less than 6 millimeters. You can define it any way you want, but really it is situation dependent. So it's a low IOP which is associated with corneal folds, with macular edema, with wrinkling of the internal limiting membrane, sometimes with disc edema. So if you have something apart from the pressure, you have some other effect going on, then you would say, okay, this is hypotony, or at least this is hypotony that I have to deal with. Any patient post a TRAB has a routine post-op examination, which includes Siedel's test and all the rest that I've listed there. Very important is gonioscopy, because we use a foam mirror gonioscope very gently. It doesn't need a linkage fluid. It sits directly over the cornea, and you try and assess what's happening on the internal opening of the TRAB. So let's take the clinical approach now. If you have a low IOP with a shallow anterior chamber or with a normal chamber depth, this is really the two options that we have. So here we have a situation of low IOP, and one has to look at the bleb configuration. So if you have a flat bleb and a low IOP, you have to assume that there's a leak. And you do a Siedel's test. If the Siedel's test is positive, there's an edge leak or maybe a leak elsewhere. You can try conservative management. As Thomas George said, you can use a large diameter contact lens. You can maybe even use glue with the lens. You can use a pad and bandage, and try and flatten that leaking edge. If that doesn't work for in about 24 to 48 hours, if it's still spontaneously leaking, anything will leak with a little bit of persuasion, especially if you have a phonics-based flap. So if you press on the bleb, it will leak. But spontaneous leak is what we are looking for with the Siedel's test. Then one has to revise and resuture. And sometimes if you have a Siedel's test negative, but still low IOP and a flat bleb, then you have to assume ciliary shutdown. Now, if we go on to the other side of that, you have a formed bleb with low IOP. That indicates that it's overfiltering. And you can try and stop the overfiltering by encouraging a little bit of scleral flap healing with pressure over the bleb. And you can do that pressure with a so-called torpedo bandage. You roll up a pledget of cotton wool till it's a nice hard little spindle-shaped thing, and put that over the eyelid and tie a pad and bandage over it. You can use Simmons shell, which is just designed for that. You can use a large diameter contact lens again, put a little bit of pressure over the bleb. And you can try interventions like fairly innocuous interventions like autologous blood injection and compression sutures. If these don't work, then you have to go and revise and resuture or find out why it's overfiltering. And sometimes you may even have to go on to doing a scleral patch graft. Looking at things a different way, early and late hypotony also needs to be thought about a little differently. In early hypotony, you have to revise in your mind what is the other factors which are controlling the flow through the TRAB. And the main thing is the amount of overlap of the scleral flap over the internal ostium. Also, the tightness and the number of sutures with which you have sutured the scleral flap. The thickness of the scleral flap does matter. And last of all, really the least important is the actual size of the ostium. Other factors which can cause hypotony would be, as I've listed before, edge leak, ciliary shock, conjunctival buttonholes which have to be sutured. Choroidal effusions do cause hypotony, chicken or the egg effect. If you have a choroidal effusion already present when you have finished your surgery, then that eye is going to be hypotonic. There are rare causes like a foreign body in the under the scleral flap, that's a cotton fiber or something like that, which is actually acting like a wick to allow more flow and keeping the scleral flap raised so it doesn't heal easily. And very rarely you can, while doing excising your trap block, you can cause a small cyclodialysis, and this will usually resolve with atropine and things. But you would have hypotony in the early postoperative period. You would be able to pick it up if you do a careful gonioscopy, but it's extremely rare. So what do we do in the examination? I've already listed these before. I won't go over it again. Gonioscopy is important. Very, very important is to do a dilated pupil indirect ophthalmoscopy, because the presence of choroidals is going to change how you're going to think about that eye and what you're going to do in the next 48 to 72 hours. So early conjunctival leaks, okay, all Fornix-based flaps leak with up to 48 hours postoperatively. If you have a spontaneous edge leak and you can see that the edge is loose, you have to resuture it, and I would usually do it under topical anesthesia, and that video is illustrative of that. So tighten the sutures, put as many sutures as you need to. You need to reform the chamber with, you first put in air, and then you need to reform it with fluid, and that fluid has to stay retained. Another option here, when you have no edge leak, but you have an overfiltration, is to use Simmons shell. And this is what the Simmons shell looks like. It's sutured with that platform over the bleb, so you're putting pressure on the bleb and you're actually pressing on the scleral flap and trying to get it to heal a little bit. The Simmons shell can be sutured onto the conjunctiva, or when we rarely use it nowadays, but you can use it just placing it within the eye and then putting a pad and bandage over that. The torpedo bandage I've mentioned before, so you take a pledget of cotton wool and roll it very tight. One little trick that I have discovered clinically when trying to assess whether one of these conservative methods is going to work is, when you have a shallow chamber like that, you support the bleb with your thumb through the eyelid, and as you can see, the chamber has formed. It was much, much flatter earlier, and now with your thumb supporting it, it has formed. That means you've got a lot of aqueous being secreted, and the moment you stop the outflow of aqueous, the chamber spontaneously forms. If you have to intervene surgically, what's the timing of the surgery? So if you have a shallow anterior chamber, that means definitely choroidal effusions have already formed. Now you can try conservative management, which consists of atropine and one of these methods I've mentioned, but it usually won't work once you've got established choroidals. If the pupillary collarate is touching the cornea, that means it's very, very close to being an almost flat anterior chamber, you have to intervene. Otherwise, you're going to get a fair amount of corneal damage, particularly in a pseudophakic eye. So what's the intervention? It's a choroidal drainage, and this is the method I use. You reform the chamber with air. You go about 3.5 millimeters posteriorly after reflecting usually in the inferotemporal area. I make a radial incision centered on that 3.5 millimeters and slowly cut down to the sclera. Use an instrument to depress and press there, and you can see the amount of fluid that's flowing out, and it will keep on flowing. And once you've adequately drained some fluid, you reform the chamber with balancol. You've already put in air, but the chamber has to stay reformed without any upthrust from behind. Stay formed with balancol, and that's your endpoint. I usually use cautery to cauterize the scleral edges so that it delays the healing of this that drainage site, and I wanted to keep draining for the next 2 or 3 days. That closes spontaneously. When I've had occasion rarely to go and re-explore the site, I find it difficult to find where that incision was made at all. The surgical interventions for early overfiltration would be to first leave an air bubble or viscoelastic in the eye and suture Simmons shell. And if that doesn't work, you have to re-explore. Re-explore means resuturing, placing additional sutures on the sclera, etc., or eventually going for a scleral patch graft. You can patch the sclera with a reflected flap of sclera like this. You Late overfiltration is indicated if the chance of infection is high. So if you have a conjunctival fistula which is constantly leaking or breaking down, and if you have hypotony maculopathy or corneal edema which is affecting the vision, you have to intervene. What are the interventions? You can try fairly conservative stuff like autologous blood injections, compression sutures, or else go on to the re-exploration and patch graft. So this is the technique of autologous blood injection. I'm going fast. It looks ghastly and it doesn't always work. In fact, it works about 50% of the time or less, but it's a very, very innocuous intervention, and I don't hesitate to use it. Compression sutures, this illustrates the compression, and they work very well. The scleral patch graft uses donor sclera, which, sorry, a little bit more. I've just got a series of photographs to show you how the scleral patch graft is done. It's important to suture at the limbus and also to put a conjunctival mattress suture. And finally, a word of warning. Hypotony is a continuing process. It leads on to choroidal effusions. The choroidal effusions can cause rotation of the ciliary body. This can cause aqueous diversion, and therefore hypotony can lead to malignant glaucoma. And here's one such case which started off with a 0 pressure, was brought to me with an 8 pressure, but had malignant glaucoma, for which I had to intervene, and had a good result. So the summary of this is that a careful post-op slit lamp examination, monitor the bleb configuration, leaks and choroidal effusions must be addressed, and you do a bleb revision or patch graft only if the hypotony affects vision. Thank you.